All right, well guys, hi. My name, like she said, is Lizzy Gilbert. First, I want to say thank you for having me here today, and thank you for coming. You know, it's important for me to get out into the community. I really believe in it, to educate about stroke, because the biggest thing is stroke is preventable. You know, and I don't know that a lot of people really recognize that or know that. And so that's why I'm here today. So again, thank you for being here. Yeah, that's my name, yeah, okay, credentials, okay. So let's just get started, okay? So here's just some basic facts, okay? Every 40 seconds, a person is suffering from a stroke, right? And so that's a lot, okay? So every 4 minutes, a person dies from stroke. So it is the 5th leading cause of death in America, and it's also the 5th leading cause of death here in the state of Ohio. Okay, I would say probably about 8 years ago, we moved from the 4th to the 5th leading cause. So that's awesome. We have a lot more work to do because I really would like for stroke to continue to move down that mortality list, right? Especially for here in Ohio. But this just kind of lets you know the basics. So really, what is a stroke? Okay, there are 2 types of stroke. So one is what we call ischemic stroke. That is majority of our strokes. So those are the strokes where you have a blood clot, okay, that either forms in the artery in the brain itself, or it forms somewhere else in the body and it travels to the brain, okay? The other type of stroke is called a hemorrhagic stroke, where you have bleeding in the brain. And that is typically caused by an aneurysm or something of that nature that ruptures, the artery ruptures in the brain, okay? So those are the 2 types of stroke, okay? About 87% of our strokes are ischemic, and the remainder would be our hemorrhagic, okay? And so, you know, again, it's kind of what I already talked about. And so what the ischemia, it's like ischemia. What that term means is a lack of oxygenated blood, okay? So there's no oxygen or blood flow getting to that area of the brain, okay? And we all know, right, that we need that in our bodies for our bodies to live and survive. And so when we don't get that to an area of our body, it dies. And so that is what's happening with stroke, okay? So that clot, if it's an ischemic stroke, is preventing blood flow and oxygen to getting to those cells in that brain, in that particular area, okay? And depending on what area of the brain it is and what artery it is, actually says what our symptoms will look like and what they will be, okay? And so that's why stroke symptoms and people with strokes can have different types of symptoms and present differently, okay? But there are hallmark signs, right? The number 1 risk factor, though, guys, for stroke is hypertension or high blood pressure, okay? Especially for our aneurysm rupture patients, okay? Because what happens is they've already got that weakening in the vessel or that aneurysm, and most of us don't know we have them. It could be that as it enlarges, you may start to get symptoms, a headache, some nausea, you know, what we call photophobia. That's light sensitivity is what that really says, okay? So some things like that you might start to get, okay? The worst headache of your life, okay, is really what we like to say when you have an aneurysm, particularly a subarachnoid aneurysm. That is where you have a rupture closer to the surface of your brain. You can also have a rupture deep down into the brain, okay? But those subarachnoids is where we hear, they call it a thunderclap headache. It's the term you will hear. But what that is, it is a headache that you've never experienced before in your life. If your head is hurting that bad, I need you getting to an emergency room right away, okay? All right, and so I like to put that out there. So TIAs, that stands for transient ischemic attack. Lay people or people in the community like to call them mini strokes, right? You've all heard of the term mini stroke, right? So that's what we call mini strokes. In neurology world and in my world, we like to call it a warning stroke, okay? And so as you can see, 5% of patients with TIAs actually have another one in the next 2 days. And then 25% have another event within 3 months. And if you really look at that, it precedes the full-blown ischemic infarction, okay? That is the full-blown stroke when I say that, okay? And so the difference with the TIA versus a stroke, a full stroke, is that it's a transient ischemia. So that means there's a clot there, but it doesn't completely occlude blood flow. It does it temporarily. Like it might lodge itself in the artery enough, right, that you get some of those stroke symptoms that, prompts you to call 911 or have a family member bring you into the ER, but then it'll just kind of continue along rather than getting stuck in that artery and completely blocking blood flow, okay? So that is what that is. So that's why we say it's a warning, because if you have a clot that's traveling through there already, right, more than likely you have damage in there that's caused that clot to form in your arteries, when I say in there, okay? Or you might have other clots, all right, traveling through your body. And so we want to pay attention to that. And so I like for people to know that if you have a TIA, through Premier Health, we still do a full stroke workup on these patients because we need to know what your risk factors are, okay? That's what's important with this, is to make sure you're managing your risk factors. And we're going to talk about risk factors here down in the slides, okay? But that's what's most important with this. Also, when we go to do our MRI, which is I call that our definitive test for stroke, we don't see stroke on the MRI, okay? So that's how we know as providers the difference between a TIA and a stroke. And there are other things, guys, neurologically that can look like stroke. We will also test for those and make sure we rule those out as well before we can even say it was a TIA, okay? So if you ever hear this term, cryptogenic stroke, that is a stroke that we don't know what caused it. We have this patient that comes in, they've had a stroke. We look at the risk factors for stroke, and this patient has none of them. And so what we find is about 25% of these patients actually are in what we call paroxysmal atrial fibrillation. That is a heart arrhythmia. It's not a lethal arrhythmia. It's not arrhythmia that will kill you. It's not one that's going to have you run into the doctor because you don't necessarily feel it, like you would some of the arrhythmias that make you, that are lethal or that make you feel really bad, right? So sometimes people can feel a bit of a flutter with it, but majority of people really don't feel that. But you can go in and out of that rhythm, okay? And what happens with atrial fibrillation is that your atria are supposed to close nice and pretty. So when your heart and your blood flows and your conduction flows through your heart, you have two ventricles and you have two atria, and they all have little leaflets that close and open like this to help the blood push through your heart, okay, and subsequently through your body. Well, in atrial fibrillation, okay, those atria kind of do this. They flutter. They don't close nice and hard, right, like they're supposed to. So you can get blood that shunts at the base of the atria, okay, but then when you go back into a normal sinus rhythm, a regular heart rhythm, okay, then you get the nice pump again, right? And think about it. If you've had clots sitting there from the flutter, and now you got this, it'll push those clots through, okay? And they can shoot through your body. Typically from your heart, it will travel to your brain. Okay, and so that is the risk of that. So what we like to do with these patients, if we don't know, because a lot of times when they come in and we do our EKGs and we put them on the monitors and everything, they are in normal sinus rhythm. Okay, because remember I said people go in and out of this rhythm. And so what we'll do is we will discharge them home on a heart monitor. Okay, so we'll have you wear what's called an event monitor. That's good for 2 weeks. If we don't find anything on the event monitor, we can then also insert what's called a loop recorder. It just kind of goes in under the skin here over your heart area, and it can record for almost a whole year or more. And that way, it helps us to catch whether we think this patient might be in atrial fibrillation. Okay. Also, there's a condition called patent foramen ovale. It's another heart condition. The heart causes the brain all kind of issues. It just causes the brain all kind of issues. And so what we do with those patients, we also do part of our stroke workup, guys, at the hospitals to do what's called an echocardiogram. And that's just an ultrasound of the heart. Okay, but what it can show us is if you have anomalies with the heart, again, that could be causing clots to form that could travel to the brain. For people with the PFO or patent foramen ovale, when we're all born, our leaflets are open. Remember those leaflets I talked about between the atria and the ventricles? Well, between the ventricles, the leaflet is supposed to close as we get older. Well, there is a segment of the population where that leaflet never closes. And you don't know it, because again, it's not something that's lethal to you, right? But we find out when we have young people especially, bless you, young people especially coming in with strokes, okay? And they have none of these other risk factors. So we can we'll refer them to a cardiologist while they're admitted for the stroke, and we can actually do what's called a closure procedure for that too. Okay, so just want you guys to kind of know what's out there, to help with these conditions and things like that. Also for atrial fibrillation, we also now have a device called Watchman. If you guys haven't heard of that or know someone who's gotten that. Again, that's an appendage device that can go into that left atrium of the heart, and it can help with keeping clots from traveling up to the brain. Okay, and it just stays in that area. Your tissue grows around it, it becomes part of your body. So it's a really cool tool. And I already talked about atrial fibrillation. I like to get ahead of myself. All right, so guys, this again, we're just going into stroke prevalence, right? So we do see it more in women than we do men. Women tend to have less aggressive primary and secondary treatment. We're kind of the caregivers of everyone else in our worlds, right? And so I really like to talk to my women in the room, those of us who are moms, and the sandwich generation. For a while I had to take care of my daughters and my parents. So guess who got put on the back burner, right? And so things like that, we have to, make sure that we're still taking care of ourselves in the midst of everything else that we do. Hormone therapy. As we go through menopause, they like to put us on hormones. Our young women, who are on birth control, especially if you're a smoker. If you smoke, you cannot be on hormone therapy. That is right there, guys. That's the #1 cascade for a blood clot to form in your body and travel anywhere in your body. Okay, so you will find that your family doctors will not put you on the hormone therapies if you're also a smoker. Okay. Then of course, gestational diabetes. What that is diabetes while you're pregnant. That's what that means. So that also increases risk for women, okay? And then, of course, hypertension. And what we find, guys, when we say gestational, meaning during pregnancy, what we find is for women who have diabetes and high blood pressure during pregnancy, we know then that that's more than likely going to be a risk factor for them even beyond pregnancy, okay? So we find that pregnancy kind of, I would like to say, tips it in, okay? And then we know we need to monitor women who have experienced this during pregnancy for afterwards. And more than likely it'll resolve after they have the baby, but as they get older in life, these things will resurface, okay? So we like to monitor our moms who deal with these. So my question is, would you be able to recognize a stroke? How many people in here think that they could recognize one? Okay, I see some yeses, I see some nos. Okay, well, let's talk about that. So your signs and symptoms, right? The biggest thing here is sudden. So remember when I talked about, either if it's a ischemic stroke, that clot lodges in the artery, it happens suddenly, right? So your symptoms will occur suddenly. If you talk about an aneurysm that ruptures in the brain, right? That happens suddenly. So again, symptoms will be sudden, okay? I'm talking 1 minute, I'm talking normal to you, and that's how it can sound and happen that quickly, okay? With the garbled speech is what we call expressive aphasia, okay? And so you have weakness or paralysis on one side of the body or another, okay? Sudden weakness or paralysis, okay? Sudden numbness or tingling on one side of the body or other. And that's the symptom that really gets people, is the numbness and tingling. Because what I find with my patients when they're coming into the emergency room, they'll say, well, at first my hand was kind of numb, and my arm was a little tingly, but I thought, it's like when you go to sleep. You know how we call it sleep? Your arm went to sleep, when you lay on it too long while you're sleeping. It feels like that. And they'll say, yeah, so I just went and laid down and took a nap. And I'm like, oh no. You'd be amazed how often I hear that. I hear it less since I've been out in the community educating, but we do hear that. And then they'll go to sleep, guys. They wake up a couple hours later, and guess what? Now the whole left side is numb. And they can't move it. And then they're scared to death, right? Because you feel like you're trapped in your body quite a bit with that, okay? And so I just really want to say numbness that doesn't go away in a few seconds is not normal, okay? So again, if you experience that or someone you're around is experiencing that, you know, and they haven't been sleeping on their arm all night, okay, or leg in a certain way. Again, even if they have been sleeping on their arm or leg in a certain way, if that does not resolve itself within literally 2 to 3 seconds, I need you to call 911, okay? All right. Double vision or trouble seeing out of one or both eyes, okay? Again, meaning it came on suddenly. That's a problem. It could be an eye problem. It could be a brain problem, okay? But again, you need to get checked out emergently to make sure of that, okay? Confusion, dizziness, difficulty with your balance. You know, they're not walking straight. They're, you know, stumbling when they walk. They look like they're going to fall every time they take a step. Strokes in the back of the brain can look like a person that's drunk, okay? So they might look like they're intoxicated, but they're not. They're having a stroke, okay? That's a clue if you see that. And then trouble with speech. So it could be trouble speaking. It could also be trouble comprehending speech, okay? So stroke, because our speech centers are on the left side of our brain, and they're in 2 different areas, okay? So this area up here, we call Broca's area. That allows us to talk and get words out. And then we have Wernicke's area back here, guys, that allows us to understand what other people are saying to us, okay? I think we're divinely made. And I say thank you that they're in 2 different areas, okay? But at the same token, if one of those are out, right? And speech, I could say, is the most frustrating symptom for stroke patients and for their caregivers, right? Because they're trying to communicate to you, and they get frustrated because they know what they want to say. They can't get it out. And it's like, oh, I can't get them to understand what I want, you know? And then it's frustrating as a caregiver because you want to help your loved one, right? And you can't figure out what it is they're trying to say to you or tell you. So that's the most frustrating, I would say. Okay. So how can you tell really quickly? This is what I want you all, if you leave with nothing else today, I need you to leave with be fast, okay? That is our acronym for stroke. This is what you can do for yourself, your loved ones, your family members to be able to detect, are they potentially having a stroke, okay? B, guys, is loss of balance, dizziness, or a headache. Remember, this is sudden onset, okay? And then E is blurred vision, eyes. Do they have blurry vision all of a sudden? Do they have double vision? Can they not see a part of your face? Okay, they've what we call a visual field cut. You know, in our world it's called hemianopia. I know, right? Say that 3 times. Okay, so yeah. And then face. Is the face symmetrical? Have them smile. Say, can you smile for me? Is one side up higher than the other? I know I'm good at this, aren't I? Guy, I've been a neuro nurse for 22 years, let me tell you. I know I look good for my age. And then A is arms. Have them hold their arms up, okay? Is one dropping? Can you tell it's really heavy? Like there are times where our patients, they're getting it up there, but man, you can tell it feels like it weighs 1,000,000 pounds to them, where the other arm or leg just pops right up, right? That's a difference, okay? You want to make note of that. And then we already talked about speech, right? Is it garbled? Can they recognize everyday items, right? Are they saying, you know, when you say the cloud, they'll say, oh yeah, cotton. Or they might say white, 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 because they can't think of the word, okay? And then T is time. That means call 911. Now, unless you live right across the street from the hospital, I'm going to ask that you please call 911. And let me tell you why. Because the EMS, right, the emergency medical system or the paramedics, they can activate the stroke alert at the hospital before you even arrive. And let me tell you, my best outcomes are from my EMS arrivals. My patients that walk through triage, let me tell you, I'm still working on that, okay? Because Symptoms can be a little bit convoluted, patients come in and, things are vague. They'll put you in a room. The doctor might be with another patient, so they'll take 10 minutes to get in there to see you before they even get you in the CAT scan. You get what I'm saying? Where when EMS calls it, guess what? We're all waiting at the door. CAT scan is holding the table. It moves, and it moves fast, and it rolls well, and we have just better outcomes. So I try to always ask my community members to just call 911, okay? Let us help you on the way to the hospital, okay? And then when you get there, we'll roll fast, I promise, okay? We go straight to CT, okay? We want to be sure there's no bleeding in the brain. That's why we do that. And then we also do an angiogram after that because we want to look at the arteries in the brain. Okay, all right. So this is just a picture of our BFAST, again, to remind you how to spot a stroke, okay? So did you know, this is just some facts. Less than half of all 911 calls were made for stroke within 1 hour of symptom onset. That sucks in my world, right? Most individuals do not realize the cause of their symptoms could be a stroke. That's why I'm here with you all today, okay? And then 53% of stroke patients utilize EMS. I want that number higher. Hence why I said, please just call 911 so I can make sure you have better outcomes, okay? All right. Time is brain. That's our saying in stroke world, okay? And this is why. So I laugh because even nurses don't even know they have this many neurons in their brains, right? And this much myelin fiber. So neurons, guys, are just the brain cells, okay? And then what our myelin is, it is the insulation along those nerve cells, okay? I used to explain it to my patients this way. It's like having a fan, right? And then you have this electrical cord that you have to plug into the wall, right, to get electricity. Okay. Well, the fan is your body, it's moving, okay? The outlet is your brain, okay? That electrical cord are all of your nerves, right? And so think about it. So what happens, right, with that electrical cord to the fan if it has a break in the insulation? What happens? Yeah, it might stop working, right? Or it might work funny, right? Because that electrical impulse now, right, is not moving along the cord, right? Because that's what that insulation helps it do, right? It might jump all over the place, okay? So your body might not move exactly the way you want it to, okay? So it's that same kind of thing with this, all right? And so for every minute delay, we lose 1.9 million brain cells for every minute. Get that? 14 billion synapses. Synapses, guys, are those areas between the nerve cells. That's how our nerves talk to each other. That's that area where the nerves talk to each other to say, move. Lift your arm, Lizzie, okay? That's my synapses working, okay? And then the myelin fibers that I talked about, 7.5 miles. You got that in your brain. Isn't that so cool? I know I'm a brain geek. I think it's the coolest thing ever, okay? And then if a stroke runs its full course, guys, so an estimated 10 hours on average, that is what the brain loses. You're talking trillions now. So this is why I'm out here, because that's what I want to prevent. This is why I need you guys calling 911, getting into your nearest hospital, your nearest ER, okay? And making sure that we get you the treatments that you need so that you're not losing all of those neurons and all of those synapses and all of that myelin fiber. The quicker we can try to reverse the stroke, the better off you will be, and the better off outcomes will be. Our treatments are time sensitive, but we're going to talk about that too. So here's our first treatment, okay? There is an IV medication that we can administer for stroke, okay? But it's time sensitive, see? Has to be given within 4.5 hours of the symptoms starting. And guess what? If we can't get when the symptoms started, because believe me, that happens, then we have to go off of when was the last time we saw this person normal? Which I hate that one. You know, I would much rather have a more accurate time. So again, if you're experiencing this, I know it's crazy to stop in the moment and think, what time is it, right? But hopefully if you have a loved one around or someone around who's there with you, especially if they witness the symptoms begin, it's important for them to really notate what time it is, okay? All right. So these drugs, guys, TPA, tissue plasminogen activator, and then we now have switched to tenecteplase. Every stroke center around the world has switched from TPA to TNK, okay? The reason for that is the tenecteplase, it's just as safe as the TPA that's been around for years. It's a little newer. It's a derivative, though, of the TPA. It sits in the body longer to do its job. But the risk factors, actually, we're finding are better, not worse. They're saying it's the same. And the risk factors for that are bleeding. There's like a 6.4% chance to bleed from these drugs because they actually dissolve blood clots in the body. These are the only drugs that do it. I said, I wish that I owned this company. They have a monopoly on the market, okay? And believe me, they own both those drugs too, by the way. You know, but it's the true clot busting medication, okay? And so we want to give this to our patients so we can dissolve that clot that's in the artery, right? But this is also why we do a CAT scan right away. When I said we go straight to CT, because if they're bleeding in the brain, I can't give this, right? We don't want to bleed them out. We don't want to make things worse, right? We're in the job of making people better. And so that is why we do this. As you can see, 30% more likely have minimal or no deficits, guys, at 3 months. And we've actually seen improvement all the way out to a year after giving this drug with our patients. So it's a good medication when we can give it, okay? The other treatment we can do is what's called intra-arterial catheter reperfusion. It's got different names. Neurointervention, endovascular therapy, but that's where they go in, guys, and they can pull that blood clot out of the artery in the brain, okay? The time frame for this is 24 hours, okay? So you have a little bigger window for this. The caveat with this, though, is that the clot has to be in a large artery. So that's why we do that CT angiogram that I told you when we do the CAT scan, we do that next test. That's to look at the arteries in the brain because they're trying to determine, do you have a clot in one of the large arteries in your brain, okay? Because if so, then we'll try to take you for this procedure, okay? And there's other criteria too I'm not gonna go into, but just so you know, okay, time frame though is really what I want you guys to know because that's what helps you get into the hospital to see me, okay? All right. So this is a before and after. So if you see there, oh, I think this is have a little, I thought it had a button thingy. Oh, well. If you see there on the left side, that is our middle cerebral artery, okay? And so it's a whopping artery in the brain. We have one on the left side and right side. And so when a clot's in that arteries, guys, it literally impedes blood flow to the whole outer hemisphere of that side of the brain. So it feeds a huge area of the brain. And so we took this patient for endovascular procedure, and now look. So you see all the little squiggly lines now on the right side? That's our arteries in the brain. They're like a bunch of spaghetti, doesn't it? Right? And so now you can see that's where the clot was, and now we've opened it back up. So this person is going to have very little deficits. They'll recover really well. They might have a little bit of therapy to do. We'll put them on medications, okay? Yeah, and they should have a pretty good outcome. So that's just a good visual for you. So are you at risk? Okay, here's where it's important, right? So risk factors. This is where I really need you guys to know your numbers, okay? We're even doing a Know Your Numbers campaign with our community health workers at Premier Health, even with us as employees, okay? I co-chaired our Healthy Living at Atrium for about five or 6 years. And, you know, I really tried my best to do a Know Your Numbers campaign because we need to be healthy to take care of you guys too, right? And so we have modifiable, those are factors you can change. There's some non-modifiable ones. So here's the ones that you can do something about. High blood pressure is at the top because what did I say? It's the #1 risk factor for stroke. Okay, I need you guys exercising, eating right, lowering your sodium, okay? And if you have to go on a blood pressure pill, go on a blood pressure pill, okay? Work with your primary care providers, okay? If it's a pill that's not making you feel good, speak up and let them know. Don't just stop it, okay? Go to the doctor and say, hey, this is making me a bit dizzy, or this is making me nauseous every day. I don't like this. You know, there's other medications out there. We got a boatload of blood pressure pills on the market, okay? You might have to try some different regimens to see what fits and works for you, okay? But I need you to communicate with your providers so that they can help you, okay? Tobacco use, and we were just talking about that at the beginning here before we started. So smoking cessation. So smoking is one of the worst things you can really do for your body. It just constricts all your arteries so you don't get good blood flow to areas. You know, it can damage your arteries, which increases the risk for stroke, okay? And it takes oxygen away from your tissues. And you need oxygen. We need oxygen to our tissues, right? To even move and function every day, right? Diabetes, okay? So what you're looking for there is A1C is 6.4 or higher is diabetic, okay? We'll say starting about 5.3 is pre-diabetes, okay? Some places will say 5.6, okay, is pre-diabetic. And then carotid artery disease. So stroke can happen here in the arteries in the neck too, guys. Our carotid arteries, we have one on both sides. It feeds the front 2/3 of our brain as blood supply, okay? And so we also do ultrasounds of the neck when we do that angiogram I told you we do when you come in with the paramedics. We also scan the neck. So not only do we look at the arteries in the brain, we also look at the arteries here in the neck, okay? Because if you have a clot here or stenosis here, we have to do something about that, okay, if it's impeding blood flow. Now, if it's not completely occluding the blood flow, guys, we'll manage that outpatient for you, okay? We still, though, will have you talk to an interventionalist. That's the person that gets the clot out the arteries. They can also go in and clean those arteries out, just like with our heart. We can do that with the brain, okay? AFib, we talked about at length. High cholesterol. So I need you guys to know your cholesterol levels, okay? And we'll talk more about those. Obesity. So, you know, with that, I really like to say sedentary lifestyle, okay? Because we've all seen reports. You know, genetics sometimes play a role. I've seen people who would be considered obese, but they work out every day. They eat great, you know? So it just really depends. So I like to say not just obesity, but I'm talking obesity with, you know, just that poor lifestyle, you know, the sedentary. You're not moving around so much. You're not watching what you're eating type of thing. And that hence inactive lifestyle. And then the hormone replacement therapies. Another one, guys, that I had added to my slides on my laptop is obstructive sleep apnea. That's another one. People have no clue, guys. It can cause heart disease. It can cause stroke, okay? Again, it's robbing you of oxygen that your tissues need, okay? It can send people into heart failure. So again, if you are waking up a lot at night, if you think you're sleeping well, but you're waking up tired every morning, have your doctor check that out. You can get a sleep study done. They have them, you can do it at home. They have machines at home, or you can go to a sleep center to get it done, okay? But that's something else, guys, that's a risk factor that you can do something about. And here's the things we can't change, right? As we get older, our arteries just become less pliable, they become less elastic, they're just at increased risk, right, for plaque buildup and, you know, damage, okay? You know, all we can do is try to be as best stewards of our arteries as possible as we age, right? That's how we prevent that. Heredity. We find people where stroke runs in the family have a higher risk of stroke, okay? Gender. We already talked about women tend to get stroke more so. Race. Our African Americans, our Native Americans tend to have a higher risk of stroke, okay? And then any prior history of stroke, of course, that now puts you at risk for another one. Because if you already have damage in your tissues to cause clots to form or atherosclerosis, plaque buildup in your arteries, then that damage is there, okay? You can't reverse that. So the best thing is prevention, okay? I already talked about that. What can we do? Control our modifiable risk factors. Guys, 80% of strokes are preventable. if we just know our numbers and just be good stewards of our own health, okay? It's okay to be selfish with your health, right? And take care of yourselves, right? Okay. Quit smoking. I know, right? Am I screaming? I'm screaming, right, on this one. All right, so this, though, is what happens when you stop smoking. Look at that. Within 20 minutes, your blood pressure, your pulse, the temperature of your hands and feet return to normal. That's within 20 minutes, okay? In 24 hours, your chances of heart attack decrease. In 2 weeks to 3 months, the circulation and your lung capacity improve. You start to be able to breathe better. You start to feel better, okay? Within a year, your heart disease risk is cut by half. 50%, y'all, that's a lot. If that were a sale at the store, you'd be running. Am I right? Yeah, And then within 2 years, heart attack risk drops to normal. Normal. Within 5 years, your stroke risk is reduced. Okay? So that's what stopping smoking will do for you. Know your numbers. So I like to let you guys know what's normal, right? So for your blood pressure, I say monitor it at home, check your blood pressure, have a machine, you can get them, just at the pharmacies, at your local, CVS, Walmart, Rite Aid, wherever you go to get your prescriptions. Check your blood sugars. Your doctor should be doing that for you though, guys. So what I would say here is go for your annual physicals, please. Okay? They should be doing what's called a hemoglobin A1C on you. A hemoglobin A1C is a percentage, it's a number. They can check it right there in the office. It's just a little finger prick they can do. All right, and it tells you though what your risk of being diabetic or not being diabetic is. Okay? And then of course they can have you go to the lab to get your cholesterol checked. Okay? So you want your total to be less than 200, and we really focus on the LDL. We love it below 70 if you can get it that low, and definitely below 100. Okay? And then your HDL, that's your good cholesterol. We like that above 40. So the higher that number is, the more your body's fighting against heart disease. Okay? Okay. So again, this is just showing you normal, what's considered pre-hypertension, high blood pressure. Okay? That's just kind of giving you the numbers because I want you guys to be informed. Okay? So that's that. Diet. Again, watch your cholesterol and fat. We want to try to bake things versus fry. Eat more of your fruits and vegetables. Gosh, if I could eat fruits all day, I would. I think they're the best. I actually have friends at work that don't like fruit. I know, right, Janella? They're like, oh my gosh. And then follow your diabetic or ADA diet if you know you're diabetic, okay? Exercise, get active, right? So exercise at least 30 minutes 3 to 4 times a week. And guys, I'm not talking it has to be strenuous, okay? I'm talking just a nice walk. Just move, okay? Try to get in your 10,000 steps if you can, okay? Take your meds the way that they're prescribed. Your blood pressure meds, your diabetes meds, your cholesterol lowering meds, okay? Anti-anxiety meds. Anxiety and stress is horrible on the body. Let me tell you, I really feel the trigger for all diseases is stress. So that's also part of this, guys. Your mental health and emotional health is important to manage and monitor, okay? So if you're having anxiety, if you're having stress, again, talk to your family doctor or provider about that, okay? Again, there's medications we can do to help that. There's natural remedies for that stuff if you're not a medication person for those things, okay? So have that conversation. Doesn't make you crazy, makes you normal. I think most of us deal with anxiety and stress, right? I can tell you right now, my job every day is riddled with anxiety and stress, okay? So I have to do things to help myself with that, okay? I like to watch TV, and I like to read, and I like to get out, and I like to be outside, and all those things that help, okay? And then of course, guys, if you have atrial fibrillation and things like that we talked about earlier, your doctor will put you on an anticoagulant. That's a drug that prevents clot formations in the body. And then we'll send every stroke patient home on an antiplatelet. That's like an aspirin. And you hear people on Plavix. Plavix is like a really strong aspirin. Okay, those are called antiplatelets. Okay. Bottom line, they help with keeping clots from forming your body. Okay. So here we are. This is a wrap up. Remember, signs and symptoms of stroke. Remember when to call 911, right? Remember your BFAST, right? Okay, take your meds as the doctor tells you or your advanced practice nurse. Know your personal risk factors and how you're going to control them. Okay. Have regular follow-up appointments with your physicians, right? Or your family provider. Okay, and those are my resources. And then one other thing I do like to preach, because we were talking about this, Janelle and I, is oral health. Please see your dentist. If your teeth are bothering you, if your teeth hurt, please go get them checked out. You know, because I was sharing, I don't know if some of you guys heard me talking while you were sitting here waiting for the program to begin. You know, I did have a pediatric patient once who had dental caries, and his grandmother had made him a dental appointment. She had just won custody of him, and he didn't make it to the dental appointment because he got too sick. He wound up on our unit. That's when I worked at Miami Valley Hospital on neurotrauma. And the abscess from his teeth spread to his brain. And so we were going to take him for surgery to try to remove that abscess and clean out his brain. He didn't make it to surgery. He had a cold blue about a night or two before that surgery was supposed to happen. And so he will always be with me, and I will always carry him in my heart. And because of that, when I'm out with the community, I preach about oral health. I was a baby nurse then. And, you know, it taught me a lesson. It was something I hadn't even thought of as a baby nurse, you know, but that can happen, you know, and it can also spread to your heart, guys. So let me add that too. It doesn't just spread to the brain. Dental caries can also spread to the heart and can cause inflammation of your valves. Okay. And that is not good either. It can send you into a complete and total heart failure. And when you're in heart failure, your heart can't pump efficiently. Okay? So that's what happens. All right. Sorry, guys.